Welcome to the Transnational VIR Journal Club session number 16 over the FEMME trial 4-year data. I'm Christopher Latour. I am a 4th-year student at the University of Houston McGovern Medical School. And today I'm here with my co-presenter, Jingle. Jingle, want to say hi?
Hi, my name is Jingyan. I go by Jingle, and I'm also an MS4 with Chris at McGovern.
Okay, so we are 4th-year students at McGovern University, and we are also the co-presidents of the VIR interest group here at McGovern. We are supervised today by our beloved faculty advisor, Dr. Alexa Levey. Dr. Levey, would you like to say hi?
Hey, everybody. Thank you so much for being here today. I'm looking forward to this presentation.
Okay, so Dr. Levey will be answering the questions that we can at the end of the meeting, and then she'll also chime in anytime she feels the need to. So, Jingle, take us away.
All right, and if at any point you have any questions or anything, feel free to unmute or type in the chat and we'll try to get to it. So just a brief outline, we're going to talk about uterine fibroids and then talk about embolization. And then we'll talk about a case and then go through the FEMME 2-year as well as the 4-year data, and then leave some time for questions at the end.
Okay, so I'm going to get us started with an overview of uterine fibroids. Uterine fibroids. So they go by a couple names. Most commonly, you'll hear the words uterine fibroid and uterine leiomyoma, like the name would suggest, for leiomyo for smooth muscle and oma for benign mass. It is a benign smooth muscle tumor of the uterus. We categorize them primarily by size and its location within the uterus. I have this picture up. You can see the most common ones are the submucosal, most close to the lumen of the uterus, intramural within the muscle, and then subserosal, which is kind of like on just underneath the serosal lining of the uterus. Next, how common are uterine fibroids? So uterine fibroids are actually the most common tumor among reproductive age women. The exact incidence of them is not completely new because we don't have any good longitudinal studies, but we have a lot of cross-sectional studies and short-term studies, and we know the prevalence of uterine fibroids varies with age, but in general, about 1/4 of reproductive aged women have a clinically significant fibroid, and by menopause, almost 70% of women have a fibroid. Previous studies have shown an age dependence. So I've drawn this little graph for you. You start off, prepubertal women almost never have fibroids. It's very, very rare to find a fibroid in a prepubertal woman. Between menarche and menopause, your probability of having a fibroid go up as you age. And once you reach menopause, the fibroids that you do have tend to decrease in size and in symptoms, and the probability of getting any more goes down significantly. So for etiology and pathophysiology, the etiology side, what causes a fibroid? A fibroid is a common phenotype for a wide variety of genotypes that share 2 factors. It is the endpoint of like a variety of different things that can go wrong within the uterus. It takes a mutated myocyte cell and the proliferation of the cell into a clinically apparent mass. How does this happen? We don't completely understand, but it involves 2 big steps. One, the accumulation of mutations in a single myocyte cell. This could be genetic, random, or both. And there are a common set of 5 genes that are they're usually mutated in these myocyte cells, and I've listed them. And then after that, this mutated cell has to start growing. And it does that by 3 main ways. 1, the masses upregulate hormone receptors. 2, they upregulate aromatases, which convert testosterones to estrogens that feed back on these hormone receptors. And they increase the vascular supply. And as interventional radiologists, this increase in vascular supply is the main reason that we are able to treat fibroids through interventional procedures. So let's see if our Polaroid is working. Who can name some symptoms of uterine fibroids? Pain, bleeding. These are good. Excessive bleeding, yes. Subfertility, Yes. Urinary frequency, sometimes. Bulk symptoms, yes. Okay, I think these are the main like 3 or 4.
Okay, so those are really good. Those are some really good symptoms that y'all put. So about 25 to 50% of women with fibroids do have symptoms, and like you said, they can vary anywhere from heavy menses to subfertility to pain, increased urinary frequency, and anemia from the bleeding. And there is a general lack of awareness of fibroids among women and their health impact. There was a survey that was done and that documented an average of 3.6 years to seek treatment, and 41% of women saw at least 2 healthcare providers before diagnosis.
Okay, so throughout this presentation, we're going to be showing you a lot of angiographic images. Jingle, can you go back one? So to understand the angiographic images, I'm going to start off with the gross pathology image, and we're going to kind of talk about how they relate. So on the right side of the screen, we have a gross pathology specimen following a hysterectomy. This is a uterus that's been bisected, and in the right part of the screen, you can see a very large subserosal fibroid and a number of intramural fibroids as well. On the left side of the screen, you can see an image from an angiogram. This angiogram is a pelvic angiogram, unilateral right side. And while you can't actually see any masses, you can see a catheter coming up on the left side of the screen, looping back around into the uterine artery. You can see the uterine artery being all, thick and loopy like it normally does. And then you see a web of vessels that kind of form a circle or an oval around something. And that something is a uterine fibroid. This is what a fibroid looks like under angiography. So with that in mind, I think we can go on to the rest of it'll just help when we see the rest of the images. So for treatment options, we usually start people with medical therapy. We can put them on OCPs, they can get on transexamic acid, and they can try a variety of GnRH agonists and antagonists. Interventional therapies would come in after this, and there are 4 main things that can be done. Surgeons can do a myomectomy, which is a surgical removal of the fibroid. The OBGYNs can do a focal endometrial curettage, but that only works if it's a small lesion and it's right underneath the mucosal surface. So it has to be a submucosal fibroid. You can also do uterine embolization. That's what we do as interventional radiologists. And then some patients select to undergo a full hysterectomy, a full removal of the uterus. Some places also do this high intensity focused ultrasound, although it's not very common. So now we're going to go over the actual procedure, the uterine artery embolization. Before we do that, quiz time. The uterine artery is a branch of what artery? Okay, I think we can show Jingle. Internal iliac. Good job, team. And then, can you find it? Which one of these is the uterine artery? Okay, let's look at the responses. Nice. Okay, so yes, that's the good job, team. That is the uterine artery. Time for uterine artery embolization. So if you are an interventional radiologist and you have a patient come into your clinic and they are talking about fibroid symptoms, here's the general approach to how you'd work it up. You start off with a history. You ask about what symptoms they have. Uterine artery embolization works best in premenopausal patients with a history of heavy menstrual bleeding. So that's what we'd like to hear the patient say if we were going to be continuing with this procedure. You also have to ask about a history of adenomyosis, because if they have fibroids with concurrent adenomyosis, it changes our approach, and it changes the type of beads and the size of the beads that we have to use. We also ask about cancer, history of current cancer, risk for cancer, because the uterine artery embolization is contraindicated in patients with ongoing malignant procedure, like cancers of the uterus and endometrium. We also do a physical exam to assess the size and mobility of the uterus, and we order a number of labs. While all patients undergoing a procedure would probably get a BMP and CBC, we specifically order a CBC to look for the hemoglobin, because most of these patients have heavy menstrual periods and we're concerned for anemia. We order creatinine and BUN to assess for kidney function, as the patients will be getting a large contrast bolus, and it's very important that they're able to clear the contrast from their system. Then we make sure that their cervical cancer screening is up to date, and most patients undergo an endometrial biopsy to rule out carcinoma before they undergo the procedure. For imaging, the first line imaging for any type of fibroid is a pelvic ultrasound. But most patients that undergo the uterine artery embolization also undergo an MRI. And this is so that we are able to know the size, exact location, and help plan the intravascular approach. So you've now worked up a patient. They've come into your office. You think they're an excellent candidate for uterine artery embolization. You schedule them as an outpatient to come in. They're in your angio suite. They're under mild anesthesia, and it's time to gain vascular access. So under ultrasound guidance, we use the Seldinger technique to gain access to the femoral artery. We upsize to a bigger and more stable system, and then we begin our catheter movements. So we wire a catheter from the femoral artery to the external iliac artery, to the common iliac artery, and then loop back down into the internal iliac artery. The image on the top right shows a catheter right at the beginning of the internal iliac artery. And the image at the bottom shows the same catheter placement, but with a contrast run. And you can see that we are, in fact, in the internal iliac artery.
Yeah.
Oh. I think somebody's accidentally unmuted themselves. I'm going to see if I can fix this. Okay, thank you. And then after we've selected the internal iliac artery, and then we move over to a microcatheter system to subselect the uterine artery. Once we're here, it's time for the embolization process. Jingle, next slide. So it's very similar to the contrast injection, except instead of injecting just contrast, we inject contrast mixed with some type of embolic agent. And the agent that we choose depends a lot on the institution that we're at, where the interventionalist is trained, and what they feel comfortable with. But the general idea is very straightforward. We are injecting a little tiny sphere that is coated, that has a specific size that we know, that is coated with an embolic substance. And in the picture in the top right, you can kind of see a pictorial image of a catheter, microcatheter, in a proximal vessel that's injecting these embolic spheres. They flow distally down towards the fibroid, where they eventually get lodged in a small vessel. In the bottom image, you can see how these beads kind of build up upon one another, and they embolize and cut off blood supply to the fibroid. The specific type of embosphere that I'm most familiar with is this 500 to 700 micrometer embosphere. This is just the one that I know. There's a bunch of different kinds, but I put a picture up, so you might be able to see this one when you guys do it. Next, we're going to go through some imaging. This is pre and post embolization angio runs of a uterine artery embolization. So Jingle, can you like, everyone focus on the left side of the screen, the pre-embolization run, and you can see contrast moving from the abdominal aorta to the common iliacs to the internal iliac, and we end here with contrast on the red arrow is the left uterine artery, blue arrow, right uterine artery, and then the yellow arrow in the middle is branches off the uterine artery that are probably supplying a fibroid. And then Jingle, can we run it back to the beginning? And if you focus on the other one, the post-embolization image, you can see the contrast running in the same pattern, but when it gets to the spot where the uterine artery previously branched off, there's no large vessels, and there's like very, very thin, loopy previous uterine arteries. This is the successful embolization of the uterine artery. Okay, so now you kind of know how UAEs work. We're going to go through a quick case example of somebody who actually came into a clinic and went through this procedure. So you are the interventionalist, and a woman comes in with a chief complaint of fibroids. She's a 45-year-old female, and she has a history of fibroids, a 10-year history of gradually worsening heavy menstrual bleeding, pelvic pain, pelvic pressure, and anemia. You go through medical history, surgical history, family history, social history, nothing new. Her vitals within normal limits. On physical exam, she has an enlarged mobile uterus that's similar in size to a 12-month-old baby, 12-week-old baby. And then on labs, CBC shows a mild anemia, like she said. Her creatinine and BUN are within normal limits. Everything else in the labs looks good. Her previous endometrial biopsy showed no concern for carcinoma, and her imaging shows a number of large fibroids. So on the pre-embolization MRI that we got, we are at the level of the acetabulum where it meets the femoral head, and I can see in the middle of the screen the uterus with 3 large fibroids in it, and on the right side of the screen, I've just copied the image and circled them. So we know where they are. Instead of walking through the whole procedure again, I've got to the point where we've already subselected the uterine artery, and we are now going to be embolizing. As you can see, the uterine artery lights up, and we have branches off of it that kind of form ovals around 3 or 4 structures, and those are the things that we're going after. So we subselect, we embolize, patient goes home, the procedure goes very well, and then they come back to our clinic a couple weeks later, and they have gotten an outpatient MRI done post-embolization. So we have the exact same image from the pre-embolization versus post-embolization. We can see one key difference. One, we're in a very similar location. I can see the acetabuli, and I can see that the superior portion of the femoral head popping through on both images. So I know I'm like mid to low pelvis. On the left side, I have 3 fibroids that are highly vascularized. And on the right side, I have 3 a little bit smaller fibroids that have no vascular supply. They are dark, 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 just like the muscle, or like the things in the outside of things that don't have big blood supplies, is what I'm saying. So I've drawn some arrows to further do this. And now I'm going to pass it off to Jingle, because while you guys now know how UAE works, when we do it and why we do it, what's the data? Is this worth doing? Should we be continuing to do this? And does it work?
Thank you, Chris. That was awesome overview on UAEs. So 2 years ago, we got the 2-year data for the FEMME trial. And then just this year, we got the 4-year data. So first we'll talk about what the 2-year data showed, and then we'll talk about what the new data shows for the follow-up. And they are slightly different. So the objective of this trial was to examine the quality of life by women who had symptomatic uterine fibroids. And they wanted to compare this quality of life if they had been treated with UAE versus if they were treated with myomectomy. The study population consisted of premenopausal women over 18 who had symptomatic uterine fibroids that were treatable with either myomectomy or uterine artery embolization. They came from 29 UK hospitals. Exclusion criteria consisted of if they had significant adenomyosis, any malignancy, PIDs, or any previous open myomectomies or UAEs. And these are some of the ones that Chris had mentioned earlier. A total of 254 women were randomized, and they put 127 to myomectomy and 127 to UAEs. So here's a good chart overview. So 127 got assigned to UAEs, and 127 were assigned to myomectomies. There were about 3 to 4 patients that were withdrawn afterwards. And in each group, not every woman received the treatment they were assigned. So for example, in the UAE group, there was 11% of patients actually got a myomectomy, and 80% got UAEs. And you can see in the intervention for the myomectomies, you have also women that got UAEs as well. So after they received these interventions, after 2 years, they were able to obtain quality of life scores for 100 patients for the UAE group and 106 patients for the myomectomy group. A little bit about the trial participants. The average age was 41 years old, and for UAEs, you can see an average age of 40.2, and for myomectomies, 42.7. The majority of patients were white, followed by Black patients, and the mean body mass was 28.1 to 28.2, which puts them at an overweight category. And about 50% of the patients in each group had desire for pregnancy when they were randomized into the trial. Some more data. Most of these fibroids were diagnosed with MRI, and Chris talked about some of the locations of the fibroids. And for most of these patients, the fibroids were in the muscle wall, followed by the subserosa. And the distribution of the fibroid was that about 50% in each group were smaller than 7 centimeters and 50% were bigger than 7 centimeters, with a mean of about 7.6 to 7.7. The majority of the patients had 1 to 3 fibroids, though about 30% of the patients had 4 to 10 fibroids, and a minority had more than 10. And as far as their past medical history goes, most of the women, about 57 to 59%, did have some contraceptive or hormonal treatments that Chris had mentioned earlier that they had tried before. Some of the women also had a laparoscopy and C-sections as well. These patients were randomized to either myomectomy or embolization on a 1-to-1 ratio, as you saw. And the myomectomy, the OB-GYN could choose to either do an open, a laparoscopic, or hysteroscopic. And the UAEs were also given some, choice by the IR attending to what they use for the embolization, and they were all done under fluoroscopic guidance. The outcome measure was the Uterine Fibroid Symptom Quality of Life Questionnaire, and they also looked at whether or not they had subsequent procedures, as well as pregnancies and outcomes of that as well. So this Uterine Fibroid Symptom Quality of Life Questionnaire assesses the symptom severity, as well as the health-related quality of life in these patients with fibroids. And this is specifically for fibroids. There's 8 items on the symptom severity scale and 29 on the quality of life. And they asked about things such as activities, mood, self-consciousness, and things like that. They're scored on a 5-point scale, ranging from not at all to a very great deal for symptom severity, and none of the time to all the time for the quality of life. And then these together are transformed to a number on a 0 to 100 point scale, and a higher score means that it's a better quality of life. So this is the FEMME 2-year results, and the data at that point showed that for 206 women, about 81% of the population that we started out with for the follow-up, the mean quality of life score was 84.6 in the myomectomy group and 80 in the uterine artery embolization group. And the between group difference that they found with regression was 8 points with a p-value of 0.01, and that's statistically significant. The peri-op and post-op complications were pretty similar in both the UAE and myomectomy, and they also looked at ovarian reserves measured by FSH and LH levels, as well as anti-Mullerian hormone at 6 weeks, 6 months, and 1 year post-op, and there was no any material difference between the 2 groups. Okay, so this is a graph just showing the mean scores over time. So on the bottom x-axis, you can see the time since the randomization up to 2 years, because this is 2-year data, as well as the mean score, which goes from 0 to 100. And you can see at baseline, actually, compared to 2 years, both the groups have increased a lot. The blue line is a myomectomy, and the red line is the UAE. But the 2-year data does show that at 2 years, there is a difference between myomectomy and UAE that was statistically significant. And you can see on this chart, the quality of life is greater on the blue line than the red line. So the conclusion at 2 years was that among women with symptomatic fibroids, those who underwent myomectomy had a better fibroid-related quality of life than UAE. And this is just a little bit of a summary. So we looked at 254 patients with symptomatic fibroids. Half went through myomectomy, half went through UAEs, and there was a statistically significant difference at 2 years. So now we'll talk about the 4-year data, which recently came out. And just showing this again, but if you look towards the bottom, this time after, so we had 100 patients from the UAE group after 2 years and 106 in the myomectomy group after 2 years. We lost 33 patients in the UAE group and we lost 25 in the myomectomy group. So we left with 67 patients after 4 years for the UAE group and 81 patients in the myomectomy group. So we looked at the quality of life scores again, and this time it was 86.6 in the UAE group and 90.2 in the myomectomy group. And this is compared to 80 in the 2-year data and 84.6 in the 2-year data for myomectomy. So we can see that they both have increased in these last 2 years. The interesting thing is that the mean difference between this was 5 points. So before it was 8 points, now it's 5 points. And the p-value is now 0.13, which is no longer statistically significant in favor of myomectomies. As far as pregnancy data, there was 15 pregnancies in the UAE group and 7 in the myomectomy group. And the cumulative repeat procedure rate was 24% in the UAE group and 13% in the myomectomy group. So this is just showing any need for further surgery between UAEs and myomectomy, and they did show that UAEs did need seem to need more surgery for fibroids. And as far as menstrual blood loss, they also looked at that, but there was no evidence of any difference in bleeding, and the majority of the women had regular to fairly regular periods. And they also did look at participant ratings as well and didn't find any evidence of difference. For UAE, about 76% of women would choose their operation again and 80% would recommend it to a friend. For myomectomy, it's the same percentage for choosing their operation and 91% would recommend it to a friend. The conclusion at 4 years is that UAE and myomectomy are both effective treatments for improving the quality of life of women with fibroids. And the advantage that we saw at 2 years with the myomectomy was not seen at 4 years. The authors concluded that both these procedures should be offered to women, including those desiring a future pregnancy. There were some limitations to the study. As you saw in the chart, we had a lot of women that were lost to follow-up. So this missing data could limit the generalizability of this result. The number of pregnant women were too small to draw a valid conclusion on fertility data. So that is a limiting factor as well. And there was decreasing quantity of follow-up data, which we talked about. And a lot of the women, when they started out, they were in their 40s. So as the trial continued, some of the women went into perimenopause and menopause. So there was less menstrual data as well. And as we saw in the chart, there was 24% versus 13% for UFVs of repeat procedures, and that could impact outcomes as well. And this is just, sorry, did someone say something? Okay, real quick. So this is an advocacy update that I got in my inbox that I thought was really interesting, and it just kind of shows, the importance of advocacy, I think. So SIR worked with legislature and they passed a new Rhode Island bill that was signed this month, and the law would be effective next year. And they said that all insurance plans that cover OB/GYN care also must provide coverage for fibroid treatments, including UAEs, which is really cool. And that will be a supported option for women to get their fibroids treated. And here's all of our references. Thank you so much for tuning in, and we will open up the floor to any questions.
If I may, first of all, excellent job, guys. This is a really good coverage of a very difficult topic with lots of papers and lots of nuance. And so these strokes here were absolutely perfect, covering all the topics. If it's okay, I was asked a question in the middle of the presentation about postoperative pain, uterine artery embolization. One of the reasons it is preferred over myomectomy is because short-term recovery. Patients actually can go home the same day. I tend to keep my patients overnight because we are infarcting things in the uterus, and that tends to hurt. So if you can get women through the first 24 hours, usually I do a PCA pump and some D5W to make them feel good. You can get them on oral pain meds, and then after about a week, they start to feel pretty great. Versus myomectomy and open surgery, they're usually in-house anywhere from 3 to 5 days, and then they have the pain from their incisions and everything else. So the recovery is a lot shorter for UAE than it is for myomectomy. And it's also a lot cheaper in the end from a hospital stay standpoint. And so that's something else that is also important to look at, that of course the trial did not look at as well, which was interesting. I'm very happy. I actually hadn't seen the 4-year data, which is also very important to look at, and something also to think about too when you're doing myomectomy versus UAE is, we talked about menses. You know, we also do UAE as well for bulk symptoms, which can cause constipation, urinary frequency, sexual dysfunction, so it can cause a lot of pain with sex. And so it takes about 6 to 12 months for UAE to fully decrease the size of fibroids in a uterus. And usually we expect to see about 40% size decrease in the uterus, versus myomectomy, you're just kind of shelling them out depending on where you are. And different locations cause different symptoms, but those are just a couple things I had to say. If y'all have any other questions.
Yeah, I would be curious about, I know there wasn't a lot of pregnancy data and birth, but I know at least with extensive myomectomy, I was wondering if there might be some structural considerations for patients preferring vaginal birth for embolization versus myomectomy.
Do y'all want me to take this, or y'all got it?
I could attempt, but I would not have a lot of useful information.
No, that's okay. So, I mean, I'm on an OB-GYN. I would still say that if people want pregnancy, it's a contour deformity in the surface of the uterus. So a lot of times removing a fibroid, particularly it's a submucosal or submucosal fibroid that causes these. Rarely intramural, that just shelling out is better, but you can cause devascularization of the uterine artery surface. So that's kind of the thing you have to look out for. If you look at all the data that's out there, initially they were saying there's less incidence of pregnancies in women who get UAEs, but if you actually look at the people who get UAEs versus people who get myomectomies, people who get UAEs are older, less healthy, less likely to become pregnant. When they looked at it in younger women and younger groups, actually found the pregnancy rates to be about equal. So those things that are also to consider. If there's differential blood supply from the ovarian arteries, then you actually need to take those out because they supply the uterus. You may cause some premature ovarian failure. Also still very low risk, but things to consider. Not sure if I answered your question. But.
You did, thank you.
I'm gonna look at the chat box, guys. I hope that's okay. Oh, good. I was right about the length of stay, Jingle. Thank you for including that, that I remembered it correctly.
Thank you.
What is the comparison and the cost? Man, so as a physician, I don't know that, and I don't have to know that, and I think that's great. What I can tell you is you can use moderate sedation. You don't have to use general anesthesia, so you decrease the bill in that way. I don't have to send stuff off to pathology, so there's 2 less bills that the patient gets, and then a hospital bed is about $1,000, $1,200 a night. For that. So that's the only thing I can comment on in terms of that for people I know who have been in the hospital. Is there a difference in pregnancy outcomes between these two? No, because I just talked about that, Eric. So I hope that you got some information. There's tons of papers out there, but usually the pregnancy rates are about the same if you actually look at the data and you look at the age of the patients. Mara et al. Yep, very good. Mara et al. Wrote a great paper. Dr. Levey, thanks for being here. Current studies looking, yes, Anna, very good. So embolic agents, so number one, most people use embospheres now, or embozine. PBA is falling out of favor because those tend to be less uniform, and they found that when they use them, you could actually cause uterine infarction. And so that's a problem. So the size B that Chris showed is typically what's used to start for uterine fibroid embolization, because they found that you can decrease blood supply without infarcting the uterus. So a side note too, by the way, is in the uterus, if these come back, is that, you know, these are abnormal vessels that are perfusing these little small benign tumors. So if you have larger tumors, they're going to suck up more of those particles than the smaller tumors will. So you can imagine the smaller tumors may maintain some blood supply and over time will come back, which is an explanation for why women over time may need a repeat procedure. So sorry, going off on that. Analgesic injection, absolutely. Some people preoperatively too will give 1,000 of Tylenol, scopolamine patch, fentanyl patch is very common. Giving 5 cc's of intra-arterial lidocaine, preservative-free, is very common to do that bilaterally. And they, while a lot of the data doesn't actually show it's, you know, good long-term, they do show that patients say that they feel better for it. I personally like to do superior hypogastric nerve blocks with bupivacaine and with a steroid block, because those tend to last a little bit longer post-procedure. The steroid allows for up to about 5 days of relief. And so that's something that I like to do. And of course, anti-inflammatory is huge. Toradol, massive after the procedure for pain relief, in order to get your patient discharged home if you want to do this as an outpatient procedure. Recurrence of fibroids. So we kind of talked about that. I personally haven't looked at that, but I just advise my patients if some of their symptoms come back, particularly bulk symptoms is the big one you look at. There's also other complications with uterine fibroid treatment, which I'm not even going to touch here. Again, this is like Jingle and Chris did a fantastic job talking about like a massive topic. I don't want to get too much into the weeds. Okay, look at that. 600 British pounds. That's a lot of money. Yep, intra-arterial lidocaine, possible use. Awesome. All right. Any other questions, guys? Excellent topic. Very hot topic debate, you know, fighting, you know, about UAE versus myomectomy between the two groups. And so, and the most important thing too, you guys touched on too, is it's really, it shouldn't be a fight. It should be collegial and kind of what the patient wants. A lot of times for bulk symptoms, myomectomy isn't going to take care of it. They need a hysterectomy. It's too big of a procedure. So UAE is something to look at for those patients in general who don't want surgery, and they're out there. And so see how you can collaborate with your OB/GYN colleagues as well.
I had a final question. I'm not sure if the answer's out there or not, but I know that there was a difference between the 2-year and the 4-year. Do you know how long the FEMME trial, the cohort, is going to be followed for? Like, for example, if there'll be a 6-year or an 8-year?
So I don't have an actual number on this, but at the end of the 4-year data paper, they say that what are some takeaways? One was that they don't need to do another study like this. They feel like they have good enough data, but they are going to continue following the patients indefinitely. And so there might be a 6-year trial, but it would be with a lot less patients. Sorry, Dr. Levey.
You guys can imagine, I mean, I'm trying to follow up patients for a year for a procedure I do, and it is hard to get patients to follow up. You know, they're busy, they have lives, and you're saying you're helping other people, and that only gets you about so many years out before patients kind of knock off. So I would be shocked if they could get it any longer. 4 years is pretty good.
All right, everybody. I think that Dr. Levey has knocked out all of the questions. If there's nothing else, thank y'all so much for tuning in. We have 17 people today. I think that's the biggest one I've seen so far. So shout out to you guys. And then I'd like to give a big shout out to Jingle as well for doing such a good job putting this all together. And Deshaun and who's my last person?
And thank you, Chris. Don't forget to give a shout out to yourself.
All right. Thank y'all. And Dr. Levey.
Thank you.
Thank you all so much.
Thank you.